Hi, I'm Dr. Steve Ratcliffe, VP of Spear Study Clubs at Spear Education in Scottsdale, Arizona. Thanks for joining me on this Heraeus-sponsored webinar. Today, I'm going to talk a little bit about implants and overdentures and hybrids. I know that there's a lot of interest in this topic, and while we can't address it in a 45-minute webinar in really great detail, I can give you an overview and some things to think about. And maybe give you some direction about what you want to learn more about so that you can offer some different services to your patients. As a way of disclosure, I am a full-time paid employee at Spear Education. I work there full-time and also work in our faculty practice in Scottsdale at the center. Heraeus sponsored this program, and they arranged for an honorarium for me to do this webinar. And they also gave me, supplied me with their Mondial denture teeth to use for the case that I'm going to show you. Let's think about Manny here. Manny is about 50 years old when I saw him a few years back. He was referred to me by a periodontist, and he came in and said, my surgeon says I need all of my teeth out. And in fact, his periodontist had told me that his dentition was terminal, and he referred Manny to me for an implant restorative consultation. So one of the things I think it's important to understand, I don't know about you, but when I first was in dental school, dentures weren't fun. I thought they were one of the hardest things that we did, and I just struggled with it. I finally met a mentor of mine by the name of Sal Esposito, who really changed my mind and got me interested in removable. And now in the world of implants, we can really do some great things for people. What's interesting is that the CDC keeps statistics on edentialism, and if you extrapolate their numbers, it becomes apparent that about 680,000 people in the U.S. become edentulous every year. That is an increasing number. Increasing due to our growing population, increasing due to the number of immigrants coming into the country who come from areas where they don't have great dental care, due to people living much longer. So this is an area of dentistry that is actually becoming larger. So I think it's an area that we really could benefit from focusing on, both for the good of our patients and also because it's an important part of practice and can become a way to become more productive. So I want to talk about an overview of the restorative options for the edentulous case. I want to talk about it with a focus on implant restorative, and then we'll show you the sequence of treatment in a hybrid case, Manny's case. Let's just take another look at Manny. These are lateral shots. You can see things are not looking real good for him. Manny has smoked for a number of years. At the time that these photographs were taken, I believe he'd stopped smoking for about 3 months. But because of almost 45 years of smoking and because of neglect on his part, his dentition is hopeless. You can see that he's had some dentistry done in the past. He's had cavities taken care of and a crown. He's got a little bit of wear on his anterior teeth, so at one time he was doing something to create the wear. But, one of the nice things about really loose teeth is that they don't wear very much because they just move out of the way. Lateral shots from the buccal. And here's the Panorex from the periodontist. You can see he's already beginning to think about where he might want to put implants. You can also see that Manny just doesn't have very much bone left around any of his teeth. So this surgeon has proposed a treatment plan that includes implants. If we think about this, how is treatment planning this case different from a case, or the same as a case that has teeth? You might think that, well, you just take the teeth out and then you go through your denture steps, and that's partly true. We go through a process at Spear Education that we call facially generated treatment planning. It has 4 parts to it. We begin with aesthetics, then we think about function, then structure, then biology. And truthfully, if you think about how we came to this, how Frank Spear came to this, along with his Northwest Dental Network, the study club he was part of. It really does have its genesis in denture prosthodontics. If you go back to that first hard class in removable when you were a first-year dental student and you think about setting up that upper denture on either a manicure or an articulator, the first thing you did was set the maxillary anterior teeth. And then depending on where you went to school, you either set the lower front teeth, but in many places you set the upper posterior teeth. And you set it so that when you took that denture off of the mannequin or off the articulator, you could put it on the tabletop, and the centrals, the canines, and all the buccal cusps of all of the posterior teeth except the distal buccal cusp of the upper second molar, all were on that tabletop. You established aesthetics, you established the aesthetic plane, the aesthetic incisal plane, and you established the line and plane of the posterior occlusion. So really, treatment planning does begin with aesthetics. Then you set the lower denture so that it could function within the framework of the upper denture that you've created. So really, that's what we're doing when we think about treatment planning any case, and especially a case that's going to become edentulous. I think it is important to kind of walk through this process that we use, because I think even with a patient who's going to lose his or her teeth, this gives us some perspective and helps us plan more about where we think we want to end up. So our process, beginning with aesthetics, has 8 steps, 4 for the upper and 4 for the lower. We're going to just talk about the upper ones here. We're going to begin with the first step, or aesthetics 1, is what we call display, or where are we going to place the edges of the central incisors relative to the face. So we've got this photograph of tooth display at rest, and Manny doesn't show a lot of tooth. He's got a very long upper lip, so he probably never will show a lot of tooth at rest, but we would like him to show a little bit. When he smiles, now this is a guarded smile, he's not really giving us all he's got. Most people don't when you take a photograph of their smile. We use this image to think about where the midline is, and we want to think about the midline in 2 planes, the vertical and the horizontal. Manny's vertical midline is off to his right by about 1/3 of a tooth. So we may want to think about how we're going to correct that in the final prosthesis, or partially correct it. The horizontal midline is pretty close. The right central incisor is canted a little bit, so you can tell that it's crowded, and it gives it the appearance of being larger than the left one. So we're going to want to change the axial inclination of his anterior teeth to give him more symmetry. So that's the midline piece. And the third part of E1 is looking at where we want incisal edge position. So I've just drawn this on the photograph. This is a tool that we teach in our class called Facially Generated Treatment Planning. You can either do it on PowerPoint or Keynote, or you can do it just draw it on an 8x10 photograph with a piece of orthodontic tracing paper over the top. So what I've drawn in here corrects the tooth position, adds some symmetry. We look at where the cervical margins of the teeth are going to be. Then the second part of that is to also look at the occlusal plane. Now we want to create some symmetry with the occlusal plane so that everything's on the tabletop, if you will. So the right posterior teeth aren't bad. The canine needs to be lengthened on the right side. The left posterior teeth have super-erupted, so they're going to need to be moved apically. Then we take this occlusal plane and just drop it down so that we can see the lower occlusal plane, and we can see that the lower anterior teeth are way above where we would like to have them. The lower posterior teeth, not so bad. So we're going to make some changes to the occlusal plane. The second step, E2, is the labial inclination of the centrals, and we do this either with a photograph of the models from the lateral, or we'll do it with a mirror shot. We just draw a line through the long axis of the central incisor on the side that we're imaging, and then draw a line through the occlusal plane. If the intersection of those lines, if that angle is about 90 degrees, the labial inclination of the front teeth is probably not too bad. In this case, he's proclined a little bit because of the attachment loss. Those teeth have drifted forward. The third step E3 is the maxillary occlusal plane. We use the same diagram, and we draw a line through the central incisors, the canines, and the buccal cusp tips. We already know that those posterior teeth have super-erupted. So when we look at the occlusal plane, we're looking to see if we need to lengthen the front teeth, shorten the back teeth, or the other way around. In this case, we're going to shorten both the anterior teeth and the posterior teeth a little bit based on the previous drawings that we saw. And finally, we're going to look at gingival levels. We know that in a pretty smile that the gingival levels all converge towards the midline, or at least the centrals and the canines are at the same level, with the laterals just a little shorter. In this case, every tooth is at a different level, and we've had significant attachment loss. So Manny has really long teeth, and we're going to want to correct that. So the drawings show us where we'd like to have those gingival levels. Function, when we begin to evaluate this, and in Manny's case, we're not going to talk a lot about this today. We're going to look at muscles, we're going to look at the jaw joint, and we're going to look at the way that the teeth contact it both in function and parafunction. Manny had no muscle symptoms, no discomfort, and his temporomandibular joints were healthy and worked normally. Structure leads us to ask several questions. We want to know what teeth are we going to keep, what are we going to restore, what will we replace, what will we take out, and how are we going to get the tooth position and the gingival levels that we want. So in Manny's case, we know we're going to be removing all of his teeth, so those questions are easily answered. And tooth position is going to depend on how we decide to place implants. Biology is just what disease processes do we need to eliminate or control, either during treatment or before we begin more definitive treatment. And again, Manny's disease will be easily controlled because we're going to take out the offending structures in his mouth, his teeth. All of the teeth come out. What are Manny's choices? Well, you know, the obvious, of course, is full upper and lower dentures. But that doesn't have to be a choice today, although many people seem to do just fine with conventional dentures. We can talk about implant-assisted prostheses, and we can talk about implant-supported prostheses. An implant-assisted prosthesis is one where stability and retention is provided by implants, but yet we still need to rely on soft tissue and bone to support the prosthesis. An implant-supported prosthesis gets all three, stability, retention, and support, either by bars that are attached to the implants or from the implants themselves. If I think about an implant-assisted prosthesis, the classic is the two-implant lower overdenture with locators or a bar. Those implants function to provide little caps with females on the implants and males on the inside of the denture. So the denture has some retention and doesn't move when it's attached to the implants. However, most of the stability or most of the support is from bone and soft tissue. The bar prosthesis also is very common on top of two implants, just a simple circular bar that goes between the two fixtures that's screwed onto the implants. And then little clips, hater clips are probably the most common, are fabricated so that they are inserted into the denture and they just snap over the bar. The denture can still rotate around the bar somewhat, but again, there's primary stability and some retention provided by the implants in the bar. When we're thinking about the maxillary arch, and particularly if we're thinking about locators, we really don't want to do two locators on the upper arch. There's just too much room for rotation and putting really heavy forces on both the abutments and on the implants. So we like to think about a minimum of 4, and we'd like to maximize the distance between the anterior and the posterior just to create less rotation. If we add a bar, it's the same kind of a thing. We'd really like to have 4 in the upper arch, again to minimize rotation and minimize torque on the implants and on the abutments. We'd like to maximize the distance, and we want the anterior bar should be perpendicular to the midline of the palate. so that there aren't any off-centered rotational forces. We want the bar, we don't want the bar in front of the implants because it creates abnormal torque. So let's look at this. If we have that bar in between two implants and the denture or the clip that's on the bar rotates around it, the torque is placed on the bar. If the bar is in front of the implant, there's greater torque placed on the abutments themselves, and that can lead to attachment loss around the implants and sometimes even failed abutments. When the bar acts as a diving board, it acts as a lever system when it's in front of the implants. Not having that bar perpendicular to the midline creates some concentrated force on the implant and bar junction that is most posterior. So there's less force on the implant on the right side of your screen, more force on the implant and on the bar junction on the left side. If we move to the lower arch, it's a similar sort of a situation, although we can do two implants for retention. And actually, not a lot of support, but some support with two implants. We'd like to place them between the metal foramina. You can't place them, if you're going to place a bar, they've got to be further forward, otherwise the bar can impinge on the tongue, depending on the width of the arch. And again, a bar and two implants still allows rotation. 4 locators is always better because it prevents rotation. And again, we'd like to maximize the distance between the anterior and the posterior. Same situation with the bar. We'd like to have 4 as a minimum. We want the anterior bar to be perpendicular to the midline, and we don't want it in front of the implants for the same reasons as in the upper arch. So we want those implants to be far enough apart to allow clips to be positioned and the bar to be placed either between the implants or slightly to the lingual. If the implants are too close together, you're not going to be able to get a clip on them. So you need to think about at least 10 millimeters between the mesial edge of the implant on either side. Implant-supported prosthesis would be implants on top of a milled bar, like the ones in the photograph, or implants that support a hybrid, or 8 to 10 implants using fixed bridge work. This milled bar is screwed to place. This particular prosthesis also has what are called passive attachments, so that the denture is shaped, the intaglio of the denture is shaped in the form of that bar. But you'll notice where the circle is, there's a little push button. That's a little lever that snaps into a receptacle on that milled bar. So the denture can't move. It is very solid, and the patient will have no movement with this prosthesis. This is a hybrid prosthesis. There is a milled titanium bar, custom milled titanium bar that is milled from an implant level impression, or at least from a rotational abutment impression. And then the teeth are fabricated over the top. The screw access holes are placed so that they're a minimum diameter, so that they don't jeopardize the integrity of the teeth or the prosthesis, and there's less breakage. An entirely fixed case can look something like this. This is a case Greg Kinzer did, one of our faculty members. It's all fixed on top of custom abutments, cast gold custom abutments. And you can see lots of pink porcelain. This prosthesis is cemented in place. If I'm going to do an implant-supported prosthesis and I'm thinking about fixed, there are several ways I can do it. I can place the implants on molars, premolars, canines, and centrals and do 4 bridges. I can do 3 bridges, so 2 posterior bridges and a 6-unit anterior bridge. I can do cantilevers, so I can do a bridge between canine and premolar with a ponic on the premolar and a cantilevered molar. and cantilevered laterals off of the central incisors. I can do a 6-unit anterior bridge from canine to canine, and then I can splint the premolars and cantilever a molar. And the way we know how much of a cantilever that we can get away with or provide for the patient is by measuring what we call AP spread. AP spread is the distance between the middle of the most anterior implants and a line between the most posterior implants, the distal of the most posterior implants. The distance between those two lines is the AP spread. So the cantilever should not exceed 1.5 times the AP spread. So if we have an AP spread of 10 millimeters, the cantilever should not be any more than 15. That's the maximum that the literature tells us that prosthesis can support without creating excessive stress on the implants or on the framework of the prosthesis. So how do you decide? Well, first, I guess before we go into that, I want to give a little pitch here for the ITI, International Team for Implantology. The ITI is a not-for-profit group that is dedicated to implant research and education. And one of the things that membership in the ITI does is gets you the ITI treatment guides that are published every year. And these treatment guides are incredible. Membership also gets you access to all of their literature reviews and any of the meetings that take place anywhere in the world. Membership is only about $300, $325 a year. So it's really, it's worth every penny. And if you decide that you don't want to join, but you still want the treatment guides, you can get the treatment guides from Quintessence. They really are very useful, and they cover a wide range of implant restorative protocols. So I really think if you're considering beginning to do these kinds of cases, this is a really valuable resource. So how do you make the decision? Well, one of the things that we believe at Spear is that you help your patient understand what their options are and what the risks and the benefits are for each option. So if I'm thinking about an implant-assisted prosthesis, the benefits are that it's removable, it's easy to clean. Sometimes in a removable prosthesis, the aesthetics are easier to achieve. Sometimes the cost is lower. There's less technical demand on the part of the dentist, and the patient can get their prosthesis faster. And usually there's less surgery because fewer implants. Now, the risks with an implant-assisted is that it's a removable prosthesis, and not everybody wants that. Frequently, there's an interim full denture that is necessary depending on bone loss, but that's true with implant-supported prostheses many times as well. The flange may create some aesthetic issues. Internal attachments need to be replaced periodically. So if you're using locators and you've got the Delrin males that are inserted under the denture, they have to be replaced every 6 months to 2 years, depending on your patient and where the implants are. If there's a bar, the patient still needs to floss. And let's be honest, people don't get to the position where they need an implant-supported prosthesis for an edentulous arch because their home care was meticulous. So chances are pretty good that if they didn't floss before, they probably won't, although some do. If I'm thinking about an implant-supported prosthesis, they can be fixed, or at least in the case of the bar-retained overdenture that has clips on it, they can be attached so that they're not movable at all. They're a great prosthesis with a poor ridge. Frequently, there doesn't have to be a flange because all the support comes from the implants. Greater stability because you've got more implants, and when they're fixed, as in a hybrid or all cemented, they act like teeth. Sometimes the prosthesis is less intrusive because you don't have a framework or a large bar if you're talking about a hybrid or a fixed prosthesis. The risks are much higher costs typically because of more implants. There is a learning curve to doing these, although once you've done a few, they're not really that challenging. Often there's more surgery involved. Sometimes there's significant grafting that needs to be done. Much harder to clean if it's screwed in place or cemented. Gummy smile cases sometimes require a lot of bone removal, as in this particular instance. This woman really wanted something that was permanently affixed, although she couldn't afford to do individual implants and bridges. So we're going to do a hybrid, but the downside to that is because of her gummy smile, it's going to require quite a bit of bone removal in order to hide the margin of the prosthesis. Now in her case, she has so much bone loss from central all the way back to the left side that she's going to lose that. The bone is already gone, but we had to take quite a bit of bone on the right side in order to get the margin out of the aesthetic zone. If you're doing fixed in a case like this, you're probably going to end up with pink porcelain to avoid having teeth that look really long. Sometimes people want to place these restorations immediately or do immediately placed long-term provisionals. We're talking about the all-on-4 concept or immediately loaded long-term provisionals. And there are some guidelines, if you're thinking that you want to do that you need to work out with your surgeon. You need to have adequate horizontal and vertical bone height in order to get primary implant stability. If you can't get implants that can be torqued to about 35 Newton centimeters in a minimum amount of bone, say 8 millimeters, then you don't have good primary stability. And loading those implants is probably not a good idea. So if you've got at least 4 in an arch, you probably can do a long-term provisional provided the AP spread is correct. In this particular case, let's go back to Manny now and just go through his case. He had pneumatized sinuses, he had severe periodontal disease. There's just no way that we were going to get primary stability with implants in his case. So we decided to do immediate long-term provisional dentures. So there's just the primary surgery. You can, the slide on the left just shows you how much bony destruction there was, and all of that was grafted. The slide on the right is the interim dentures in place. This is 72 hours after Manny had all of his upper and lower teeth out, so he's still pretty puffy. This is 3 weeks later, so already he's looking much better. Now those interim dentures need to be relined periodically. We use a soft liner material called Permasoft. I like that material because it can be mixed in different consistencies and you can vary the hardness of the reline. So as the tissue was remodeling and shrinking, the denture would get loose and we'd just do a reline. So there's 3 weeks. These denture teeth are the Heraeus mondyle teeth, and you already know that Heraeus gave me these teeth for this case, but actually I use them for most of my prostheses anyway, where I'm doing anything in acrylic. I love the aesthetics of the teeth, I love the hardness of the teeth and their resistance to wear, so I think they're just really beautiful, beautiful teeth. And I like the mold selection as well, so lots of choices and shades. So there's pre-op and there's 3 weeks. At about 4 months for the lower arch, Manny had healed enough that we could begin to do the prosthesis. And in this particular case, we decided to do guided surgery. We decided to do it so that the second surgery could be flapless. We wanted precision placement of the implants. And we wanted to immediately load the implants with a long-term provisional before we converted the hybrid. So in order to get to that point, Manny needed a duplicate denture for a short period of time, and I did a hard reline of his existing denture because I wanted the best possible fit I could get on that reline denture. So I just used a denture duplicator in jet acrylic, and he wore the prosthesis on the right for 48 hours. The relined denture was sent to the laboratory that I was using for this particular case, and they duplicated it exactly and made a scan denture that is laced with barium. I bring the scan denture back. I make sure that the bite is correct, that it's the same as the other denture was, and we squirt a little bit of clear bite registration paste. This happens to be, actually this is Memicil by Heraeus. It's not a bite paste, but it's a clear matrix material that I like. So that just, it's radiolucent, so it doesn't show up on the scan. So the scan is done, and then we can do the denture plan, or the implant planning. The surgeon and I sat down and talked about where we wanted them and designed the prosthesis. The laboratory returns to us this long-term provisional. Now on the left side of the screen, the provisional is snapped into a clear carrier. The carrier fits exactly like the reline denture, so it's a precision fit. That long-term provisional snaps into that carrier, so it doesn't move at all. The carrier is going to allow us to seat that denture over the top of a temporary abutment on an implant. On the right side of the screen, you'll see the surgical guide with different colored sleeves that indicate different depths for the implant. So the surgeon knows that he uses drills that are color-coded to those sleeves. It allows him to just take the drill to the top of that metal sleeve, and he knows that he's at the exact depth that he needs to be. My implant system of choice is Straumann. I like their restorative components. These are Straumann bone level implants. As you can see, this was done flaplessly, and we put the mounts back in on the left side so you could see them in place. This is a temporary abutment that is screwed into a single one of the implants. Then the carrier with the long-term provisional snapped in place is seated over that abutment. We look at the length of the abutment, and we shortened it a little bit because I don't want that abutment to stick up above the pink acrylic there. Once we've got the abutment at the right spot, I hold the denture down and I'm squirting auto-polymerizing or dual-cure pink triad into an access hole that's right where that syringe tip is. There are access holes for every one of the implant sites. Manny then bit down on the denture because it's exactly the same bite on a very stable carrier and held it in place while we light cured that resin, and the rest auto-polymerized. So he holds it in place for about 5 minutes. We unscrew that one abutment and snap the carrier out, and then we can screw that provisional back onto the single implant and also add other temporary abutments. So we've got a very stable situation because of the one abutment that was attached. Then we just go around and attach each additional abutment. So there you see all 6 abutments in place with the triad around them. We fill the holes with Teflon plumber's tape because it's easy to put in the holes and doesn't stick to anything. And then the holes are filled up with more of the light cured triad. So now the bite is finalized to make sure it's exactly the way the denture fits, so that the occlusion is duplicated with the denture. Then we do the same thing in the upper arch. So this is the carrier tried in against the lower long-term provisional. I want to make sure that the bite is correct. Those are the implants in place those are multi-base abutments on top of the implants, and the temporary abutments are screwed on top of those. Here you see the abutments in place, and there's the prosthesis in place. So Manny was going to have this prosthesis for about a year before we converted both the upper and the lower to hybrids. Unfortunately, he lost his job, and it stretched on for a while. At 2 years, he still wasn't ready. At 3 years, this long-term provisional is showing us why it's a provisional. The access holes for those temporary abutments are very large, so it creates weak spots in the prosthesis. And you saw the wear that occurred on Manny's teeth when he had his natural teeth. So Manny still does a little bit of clenching and grinding. So he was able to put enough force on this that it broke the prosthesis. That also gave us some clues, though, into the final occlusion on the hybrids. So now we're going to convert. We've got 6 implants in this upper arch. There's a 7th implant that was added at a later date that we decided not to use because it's so far posterior. We're going to use an open tray impression technique. So these are implant transfer posts that are screwed into the abutments on top of those multi-base abutments, and I can access them through the tray. The impression is made, and those transfer abutments are unscrewed to remove the impression. Then we pour a model that has the soft tissue model with multi-base analogs in it, so it looks exactly like it does in the mouth. We want to verify that, so we make what's called a verification jig, and we take that back to the mouth. It has to seat passively without any resistance to rescrewing those transfer copings back into the implants. If there's any resistance, or if any of those transfer copings are not flush with the abutments, either we need to remake the impression or we need to do some modification of the model. In this case, everything fit well. You notice that I used Improgum, a polyether impression material. I typically use that for my implant impressions because it's so much more rigid than other materials. Some of the vinyl polysiloxane materials just aren't stiff enough, and the transfer copings can move a little bit, and I just don't like that. Now we go through the same steps that we would go through with a denture. We do a wax rim try-in, it screws in, and we alter the wax to get the tooth position that we want, to get the lip support and the phonetics. That goes back to the lab, and they set the teeth and send me back a try-in. So the denture is then screwed in, we check the occlusion. If everything is okay, it goes back to the lab and it's processed. Notice how much smaller these holes are, the screw access holes, than they were in the long-term provisional. I want them as small as we possibly can and still get the screws through. In this particular case, we decided to take a little bit of a risk. The cantilever shouldn't be more than 16.5 millimeters, but in his case, it's 22 millimeters. We tried something new with a long reinforced titanium bar, and he actually doesn't have any occlusion on the distal of that molar, so the actual force can only be exerted up to about 18 millimeters. It's been in for 2 years, so far so good. Probably not what I would do in every case, but it's working for Manny. There's the case in place. I like to use a resin material that is easy to see when I put the plugs in where the openings are. I like to take these out every 12 to 18 months and clean them. Patients sometimes will clean underneath them and they'll use a water pick, but typically, as I said, they don't do a great job. So I want to take them off periodically and do that, and then I replace the screws probably every 18 months to 3 years, depending on the patient. So here's Manny's final case. He's happy, it works well, it's been there, like I said, for a couple of years now, and he's a happy guy. So thanks for being with me. If you have any questions, please feel free to email me at sratcliffe@speareducation.com. Thanks.